depression, mood instability, anxiety, decreased concentration, considered to be normal in response to fluctuating hormonal levels, the stress of childbirth, and increased responsibility of motherhood. It occurs in 50 to 80% of mother begins 2 to 4 day postpartum, usually lasts 48 hours and can last up to 10 days. It does not require any psychotropic medication. They are usually mild or absent. Feeling of inadequacy, anhedonia, thoughts of harming baby, or suicidal thoughts. Either they are mild or usually absent in postpartum blues. Now, the second one is a major depressive disorder with peripartum onset, that is a postpartum depression. Clinical feature is this specifier can apply to a major depressive episode with onset during the pregnancy or within 4 weeks following the delivery. So it basically starts during the pregnancy and it stays after the delivery also for at least 4 weeks. Typically lasts 2 to 6 months. Residual symptoms can last up to 1 year. May present with psychosis. It's rare, but some more frequent with the prior postpartum mood episodes and postpartum mania. Severe symptoms may include complete disinterest in baby, suicidal, and the infanticidal ideation. Epidemiology, it occurs in up to 3 to 6 months of the mothers, up to 50% risk of recurrence. Now, what are the risk factors? Previous history of a mood disorder, that is postpartum or otherwise generally. Family history of a mood disorder. Psychosocial factors, that means stressful life events, unemployment, marital conflict, lack of social support, unwanted pregnancy, colicky, or the sick infant. Treatment is psychotherapy. It can be cognitive behavioral therapy or IPT. I think IPT is interpersonal therapy.
Yeah, I
Yeah,
think so.
yeah. Short-term safety of maternal SSRI for breastfeeding infants. Established long-term effects of unknown. Short-term safety we can see for the SSRI in the breastfeeding, but long-term effects is still unknown. If depression is severe or psychotic symptom present, consider ECT, electroconvulsive therapy. What is the prognosis for major depressive disorder with peripartum onset? It impact on child development, increased risk of cognitive delay, insecure attachment, behavioral disorder. Treatment of mother improves outcome for child at 8 months through increased mother-child interaction. So we'll start next, anxiety disorders.
Yeah, these are
Okay.
also MCC objective.
Okay, sure. Definition is fear is a universal human experience which can serve as an adaptive mechanism to facilitate appropriate reaction to external threat. So, anxiety may be seen as pathological fear when fear is greatly out of proportion to risks or severity of threat. Response continues beyond existence of threat, that is prolonged, excessive, etc., or becomes generalized to other similar or dissimilar situations. Social or occupational functioning is impaired. So it is so aggressive that it can impair the daily life functioning. Manifestation of anxiety are as a result of activation of sympathetic nervous system and can be described through physiology. What is the physiology? It is the main brain structure involved is the amygdala. Neurotransmitter involved include 5-HT, that is a serotonin, cholecystokinin, epinephrine, norepinephrine, and DA, that is a dopamine, I think. Psychology once thought about a given situation or stimulus contribute to the feeling of fear and perception of threat. Behavior anxiety can lead to avoidance, which can perpetuate the fear or avoidance, often comorbid with substance use and depression. More than 50% have multiple anxiety disorder. When started medication for anxiety, start low, go slow, aim high, and explain symptoms to expect prior to initiation of therapy to prevent non-adherence due to side effect. Psychotherapy, individual or the group CPT. Now, what is the differential diagnosis of anxiety? That is if the cardiovascular post-MI, arrhythmia, congestive heart failure, pulmonary embolism, and MVP, respiratory asthma and COPD and pneumonia, endocrine hyperthyroidism, hypoglycemia, hyperadrenalism, hyperparathyroidism, metabolic vitamin B12 deficiency, folate deficiency, porphyria, hypoxemia, hypercalcemia, neurological neoplasm, vestibular dysfunction, encephalitis, trauma, contusion or hematoma, MS, temporal lobe epilepsy or migraine, infection, that is a cerebral meningitis, HIV, syphilis or systemic, GI gastritis, esophageal spasm, and substance use, that is intoxication either due to cannabis, amphetamine, cocaine, thyroid replacement, over the counter medication, caffeine, withdrawal due to the benzodiazepine, or alcohol. What is the medical workup of anxiety disorder? Only proceed with the medical workup as clinically indicated. That is routine screening. You have to check the vitals, physical examination, complete blood count, electrolytes, thyroid function test, glucose, ECG. Additional screening, it has extended electrolytes, vitamin B12, beta HCG, folate, chest X-ray, and any other test as per differential diagnosis in table 2. What are the risk factors for the development of the anxiety disorder? It can be the biological or psychological. In biological, it can be due to endocrine disorder, that is hyperthyroidism. It can be due to the respiratory, as asthma and COPD or pneumonia, CNS condition, that is a neoplasia, neoplasia, and what was neoplasia or vestibular dysfunction, encephalitis, substance medication abuse. It can be stimulant, that is cannabis, amphetamine, or chronic medical illness. Personal or family history of anxiety or mood disorder. XX, that is female, is affected more than XY, that is male chromosomes. Psychological, that is current stress, early childhood adversity or trauma, early parental loss, or parental factors. Now, what is the panic disorder? DSM-5 diagnostic criteria for the panic disorder. That is recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes and during which time four or more of the following symptoms occur. So at least four or more than four can be present. There, it includes palpitations, that is pounding heart, accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain, discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, or faint. Chills or heat sensation, paresthesia, that is numbness or tingling sensations. Derealization, that is feeling of unreal reality or depersonalization, being detached from oneself. Fear of losing control or going crazy, fear of dying. B, at least one of the attack has been followed by 1 month or more of one or both of the following. That is persistent concern or worry about additional panic attack or their consequence, a significant maladaptive change in behavior related to the attack. C, include the disturbance is not attributable to the physiological effect of substance or another medical condition. D, the disturbance is not better explained by another medical disorder. So, what is epidemiology? Lifetime prevalence includes 5%. One of the top five most common reason to see a family physician, male, female equals to 1:2 into 3. So, females are affected more. Onset average early mid 20s, familial pattern, comorbids. Generally, there is a depression, agoraphobia, medical comorbids. Treatment, pharmacological or psychological treatment together can be very effective. So what includes the psychological? It includes CBD exposure, graduated exposure to unpleasant sensation of arousal associated with a panic attack for experiential disconfirmation of their fears, cognitive restructuring, addressing underlying belief regarding the panic attack, and relaxation technique, that is a visualization, box breathing, or psychoeducation. Pharmacological first line agent is SSRI, then there is SNRI, then there is a combination, that is with SSRI and SNRI. Start with low doses and titrate up as tolerated. Anxiety disorder often require treatment at higher dose for a longer period of time than depression. So in anxiety disorder, we have to give a higher dose, but we have to continue it for longer period of time as compared to the depression. In depression, full response may take up to 12 weeks. Treat for up to 1 year after symptoms resolve to avoid the relapse. Explain expected adverse effect prior to initiation of therapy to prevent non-adherence. Other antidepressant, mirtazapine, tricyclic antidepressant, benzodiazepine considered second line. Short-term, lowest effective dose, helpful while titrating antidepressant. So we can use it along with antidepressant, but we need to until unless we are titrating the antidepressant medication, like dosage is increased, we can use benzodiazepine along with it. So, what is the prognosis? 85% can achieve good result. 10 to 20% continue with significant symptoms. Longer term, 65% achieve the remission. Clinical course is chronic but episodic with psychosocial stressor. So, there was a mechanism of panic attack, that is, situational trigger can result into the panic attack, which can cause mentally associated with situation, which increase the anxiety and generalization to other situation that eventually leads to situational trigger. Criteria for the panic attack is greater than 4 of the symptoms should be present. That is, students fear, the 3 C's, that is the mnemonic for it. That is S for sweating, T for trembling and shaking, U for unsteadiness and dizziness, D for depersonalization, derealization, E for excessive heart rate and palpitation, N for nausea and abdominal distress, T for tingling and numbness, S for shortness of breath, F for fear of dying, losing control, going crazy. 3 C's stands for chest pain, chills, hot flashes, or choking. So duration typically 5 to 10 minutes. Panic attack versus panic disorder. So panic disorder require recurrent, unexpected panic attack plus fear of another panic attack. What about the panic attack? It can occur in the context of many different disorders. Starting medication for anxiety, start low, go slow, aim high, and explain the symptom to expect prior to initiation of therapy to prevent non-adherence due to side effect. Agoraphobia, that is DSM-5 diagnostic criteria for agoraphobia, mark fear or anxiety about 2 or more of the following 5 situations. So it can be using public transportation, being in open spaces, being in enclosed places, standing in line or being in crowd, being outside of the home alone. B, the individual fear or avoid the situation because of thought that escape might be difficult or help might not be available in the event of developing panic-like symptom or other incapacitating or embarrassing symptoms. The agoraphobic situation almost always provoke fear or anxiety. The agoraphobic situation are actively avoided, require the presence of companion, or are endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger posed by agoraphobic situation and to the socio-cultural context. The fear, anxiety, or avoidance is persistent. That is typically lasting for greater than 6 months. The fear, anxiety, or avoidance cause clinically significant distress or impairment in social, occupational, or other important area of functioning. If another medical condition is present, the fear, anxiety, or avoidance is clearly excessive. The fear, anxiety, or avoidance is not better explained by the symptoms of another mental disorder and are not related exclusively to obsession, perceived defect, or flaws in physical appearance, reminder of traumatic event, or fear of separation. Agoraphobia is diagnosed irrespective of the presence of panic disorder. If an individual presentation meets criteria for panic disorder and agoraphobic, both diagnoses should be assigned. Treatment as per specific panic disorder. So, generalized anxiety disorder, the DSM-5 diagnostic criteria for generalized anxiety disorder, excessive anxiety and worry, that is apprehensive expectation occurring more days than not for at least 6 months. About a number of events or activities such as work or school performance, the individual finds it difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms having been present for more days than not for the past 6 months, like restlessness or feeling keyed up or on edge, being easily fatigued, difficult concentrating or mind going blank, irritability, muscle tension, sleep disturbance, difficulty falling or staying asleep, or restless, unsatisfying sleep. The anxiety, worry, or the physical symptom cause clinical significant distress or impairment in social, occupational, or other important area of functioning. The disturbance is not attributable to the physiological effect of a substance or another medical condition. The disturbance is not better explained by another mental disorder. Criteria for generalized anxiety disorder, there should be at least greater than that of the 3 features present. That is, C first is the mnemonic for the generalized anxiety disorder. C C for concentration issue, F for fatigue, I for irritability, R for restlessness, S for sleep disturbance, and T for tension, that is muscle. Epidemiology, 1 year prevalence, 1 to 4%, lifetime prevalence, 6%, male to female ratio. The again, female is affected more than male. 8% of all who seek primary care treatment. In primary care, 70% initially present with the physical symptoms as main concern. So generally in the primary care, the physical symptoms are present as compared to that of other symptoms. Bimodal age of onset, it can present like early age, like 20, or the middle adulthood also. Treatment lifestyle, avoid caffeine, ethanol, sleep hygiene. Psychological, that is CBD, cognitive restructuring, muscle relaxant technique, mindfulness. Biological, first line is SSRI, acetylopram, sartolene, paroxetine, SNRI, venlafaxine, XR, duloxetine, pregabalin. Benzodiazepine considered second line. These are considered short term, lowest effective dose, helpful while titrating antidepressant in the same way as we used in, used in panic disorder. Beta blocker not recommended. Prognosis good with treatment, depends on pre-morbid personality functioning, stability of relationship, work, and severity of environment stress. Now, what is social anxiety? Definition: marked and persistent for greater than 6 month fear of social or performance situation. So it should be present for greater than that of 6 months. Fear of social or performance situation in which one is exposed to unfamiliar people or to possible scrutiny by others. They fear that they will be negatively evaluated in a way that may be humiliating, embarrassing, or lead to rejection, like public speaking, initiating or maintaining conversation, dating, eating in public. Situations are generally avoided or endured with intense anxiety and cause significant distress or impairment in functioning. Lifetime prevalence is 8 to 12%, male to the female ratio. This is only social anxiety where they are equally affected. Phobic disorder. Should I continue with the phobic disorder?
Yeah, sure.
Okay. Phobic disorder. They are the specific phobic definition: marked and persistent for greater than 6 months. It is also present for like 6 month fear that is excessive and unreasonable, fueled by the presence or anticipation of the specific object or situation. Lifetime prevalence is like male and the female ratio is variable. Types, it can be like animal or insect, environmental related, like for heights and storms, blood injection and injury. It can be situational, like airplane, closed spaces, or other like loud noise, clowns, multiple fears. Diagnostic criteria for phobic disorder, like there should be marked fear, anxiety about a specific object or specific situation. Exposure to stimulus almost invariably provokes an immediate fear, anxiety response, may present as a panic attack. Phobic object situation is actively avoided or endured with intense anxiety. Fear, anxiety out of proportion to actual danger, socio-culture context, and persistent, that is lasting 6 months or more. Person recognize fear as excessive or unreasonable. Significant impact on daily routine, that is occupational, social functioning, or marked distress. Treatment is psychological, that is psychoeducation, CPD, focusing on both in vivo and virtual exposure therapy, gradually facing fear situation, biological minimal role for medications. So generally, I think all the anxiety disorders we should rule out, like in the history, that this conditions is not related to any other substance abuse or medical condition. And generally all the medication treatment is like CBD, ECT, or SSRI, SNRI. Generally the benzodiazepine we use only when we are using antidepressant medications to just titrate, and then we can use the benzodiazepine. That's all I can get from my topic which I read.
Yeah.
So should I start with obsessive compulsive and related disorder? We should stop here. Like,
Yeah, but like there are few charts if you want to quickly
yeah,
go.
yeah, we can go through it. Yeah,
So the anxiety.
yeah. Okay, anxiety and the trauma related disorder. So adjustment disorder. Clinical features, mood and behavioral symptoms onset within 3 months of identifiable stress. So there should be a stress within the 3 months. This will eventually cause the mood and behavioral symptoms. There should be marked distress and impairment, functioning impairment, but it should not meet the criteria for any other condition, DSM-5 disorder. Differential diagnosis, normal stress response, that is, if it should be present, that it should be not be so excessive, it shouldn't cause significant impairment
Yeah, I
in
mean, this is normal, right? Like it's
yes, normal.
okay.
Acute stress disorders, how will we differentiate it from this? There should be a traumatic event and intrusive re-experiencing, like we should have nightmares, or I think like this, what they meant.
Yeah.
Major depressive disorder, how will we differentiate adjustment disorder from major depression? That is at least greater than 2 weeks, 5 out of 9 symptoms, we read that. And depressed mood plus psycaps, that is sleep, insomnia, appetite, guilt, concentration, um, I think apprehension, psychomotor, suicidal ideation, that's all. Management is like psychotherapy is the treatment of the choice, adjunctive pharmacotherapy, short term, reserved for rapid relief of impairing symptoms like sleep aid or anxiolytic. Yeah, journal anxiety disorder, I think. Yeah. Okay. Journal anxiety disorder, the clinical feature is excessive, uncontrollable worry, that is multiple issues, that is for greater than 6 months. The duration is like greater than 6 months, but at least three of the following symptoms should be present, that include restlessness, feeling on the edge, fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbance. 6 months mean it is chronic, fluctuating course, academic and occupational dysfunction. It is also causing a significant distress. Associated feature is physical symptoms related to attention. We read that in general anxiety disorder, the physical symptoms are present. In that way, the patient is diagnosed actually for the general anxiety disorder. Physical symptoms include headache, neck pain, comorbid depression, substance use common, increased risk of high healthcare utilization, cardiovascular event. The best treatment of the choice is CBD, SSRI or SNRI, or buspirone.
So,
Panic. I think panic disorder, we read that.
yeah.
Yeah. Okay. Clinical feature for the panic disorder is a recurrent and unexpected panic attack with greater of four of the following. So it includes chest pain, palpitation, sweating, shortness of breath, choking, trembling, nausea, chills, dizziness, presthesia, derealization, depersonalization, fear of losing control or dying. Worry about additional attack and avoidance of the avoidance behavior. Treatment first line maintenance therapy is SSRI, SNRI, and or coagulative behavioral therapy. Acute distress, then we need to take the benzodiazepine. Acute stress disorder, clinical feature is duration is greater than 3 days and less than 1 month. So, exposure to actual or threatened trauma, symptom from following categories, that is avoidance of internal memories or external reminder, intrusion, that is nightmare and flashbacks, dissociation, amnesia for event, derealization, arousal, insomnia, hypervigilance, startle, negative mood. Management, trauma focused brief CPT. Consider medication for insomnia, intense anxiety, monitor for PTSD, that is symptom duration for greater than 1 month. So in acute stress disorder, it is present less than 1 month, but in PTSD, the symptoms are present for greater than 1 month. So, post traumatic stress disorder, the clinical feature is exposure to life threatening trauma. Again, it's the same nightmares, flashbacks, intrusive memory, avoidance of reminders, dissociation, emotional detachment, negative mood, decreased interest in activity, sleep disturbance, hypervigilance, irritability, but the duration is greater than 1 month. Treatment is trauma focused CBD, the same like acute stress disorder, antidepressant, same like no, it's not same like PTSD. So SSRI and the SNRI.
So here it is life-threatening trauma or
Yeah,
something like very severe, and here it can be any
any stress.
stressor can be present. So I think we have done all the anxiety disorders.
Yeah.
So